Assalamu alaikum. This is part 1 lecture on persistent and intractable hiccups for ENT trainees and students. Part 2 with MCQ questions will follow next.
A hiccup is an involuntary and abrupt contraction of the inspiratory muscles, mainly the diaphragm, but also with contribution of other accessory respiratory muscles, including the intercostal muscles. This results in a sudden gush of air into the lungs, which is followed immediately by a sudden closure of the glottis, and this creates the distinctive hic sound. It affects all ages, even the fetus. Males are affected more in general, but it is the intractable or the prolonged type of hiccup may affect both sexes equally, only that the types related to psychogenic origin may affect females more, and the organic types, organic etiology, would affect the males more. Benign hiccups are extremely common. They can be caused by gastric distension from either excessive food or drinks, alcohol consumption, aerophagia, or drinking carbonated beverages, but also a sudden change in either the ambient or the GI temperature by cold showers, drinking hot or cold beverages can cause benign hiccups. Sudden excitement and emotional stress are also known to cause hiccups. Persistent or intractable hiccups can lead to things like malnutrition, weight loss, dehydration, fatigue, depression, insomnia, and will ultimately reduce the quality of life. A hiccup is a respiratory reflex. But why do we get hiccups in the first instance? One modern hypothesis for this is the phylogenetic hypothesis suggested by a group of international respiratory researchers who suggest that hiccups are evolutionary remnant of earlier amphibian respiration. This is how the early amphibians' respiration is, including tadpoles, for example. They could show that the motor pathway that enables hiccuping is well formed during the intrauterine life before the motor pathway for normal lung ventilation. They can also show that both hiccups and amphibian gulping are both inhibited by elevated carbon dioxide levels in the blood, in contrast to normal ventilation, which is usually stimulated by the elevated carbon dioxide levels. They can also show that hiccups and amphibian gulping are both stopped by GABA B receptor agonists. It's of interest to know that the premature infants spend a considerable amount of their time, about 2.5% of their time, just hiccuping during their intrauterine development. Although hiccups are extremely common, persistent and intractable hiccups are rare. In a general hospital, about 55 patients with a primary diagnosis of hiccups were admitted out of 100,000 patients. Hiccups are common in GIT and CNS conditions. 20% of Parkinson's disease patients may present with persistent hiccups. 10% of patients who have reflux may complain from recurrent hiccups. The prevalence of persistent hiccups in advanced cancer patients receiving palliative care may reach about 4%, and this would increase to about 25% if the cancer type is esophageal carcinoma. Hiccups are classified depending on their duration to three groups. The acute hiccups would last for less than 48 hours. Persistent hiccups would last more than 48 hours but less than a month. And intractable hiccups would last for more than a month. The pathophysiology. The activation of the hiccup center would lead to the release and stimulation of various neurotransmitters and neuroreceptors in the brainstem and upper part of the spinal cord, including those for dopamine, serotonin, opioid, calcium channel, and gamma-aminobutyric acid pathways. These form the basis for the management, the pharmacological management of the intractable hiccups. The stimulation of these receptors would lead to the excitation of the phrenic nerve, usually on one side, the left side, and this would lead to a diaphragmatic contraction. The sudden gush of air through the glottis would be followed by sudden closure of the glottis, approximately 35 milliseconds, and this will give the characteristic noise of the hiccup. And the cycle can then repeat itself between 4 and 60 times in a minute. The rate of the hiccups is influenced by the level of the carbon dioxide in the blood, so that increasing the level would lower the frequency of the hiccups, and this again forms one part of the management. On the other hand, the hyperventilation, which washes out carbon dioxide in the blood, would lead to an increase in the number of hiccups per minute. The glottic closure is a protective mechanism because without it, like if the patient has, for example, a tracheostomy, the patient can hyperventilate easily without stopping the glottic flow, and this would lead to wash out of carbon dioxide and increase in the frequency of the hiccups. What causes prolonged or intractable hiccups? Because the afferent limbs of the reflex extends from the abdomen, the thorax, and the neck to the hiccup center. Any abnormalities in these areas can cause irritation and initiation of the reflex, including mainly problems with the distension of the stomach or irritation in the stomach or reflux tumors or problems in the lower part of the esophagus, hepatosplenomegaly, subphrenic abscesses, and various other abdominal problems. In the thorax, things like myocardial infarction can cause hiccups, pneumonia, esophageal tumors, and irritation of the phrenic or the vagus nerves in the neck by a goiter or cyst or a tumor can also cause hiccups. So this is a very wide range of pathologies that can cause the prolonged hiccups, and these are the basis for the diagnosis and the investigation of any case of intractable hiccups. The main thing is that patients that we often see in the hospital are those patients who have gastric stasis or distension, or those who have prolonged hiccups after operations or after various anesthetics, or those patients who have cancer, advanced cancer, and are receiving chemotherapy. In addition to the local causes, there are also general causes for the persistent and intractable hiccups, including metabolic or toxic causes, like things like hyponatremia, hypokalemia, hypocalcemia, hypocapnia, renal impairment, diabetes, and alcohol intake, or pharmacological agents. Steroids would cause sometimes hiccups, dopamine agonists, chemotherapy, and things like opioids and barbiturates, and some antibiotics, particularly the macrolides. Surgical intervention, either by irritation of the pharynx by intubation or the anesthetic agents itself, operations in the thorax or the upper abdomen, endoscopy, or placement of central venous lines, and sometimes psychosomatic conditions like anxiety and excitement and stress can also cause intractable hiccups. The initial investigations for all patients would include things like a full blood count and urea and electrolytes. Other more specific investigations will be directed by the clinical diagnosis or the clinical suspicion. And you could look for inflammatory markers, for example. You could look for certain enzymes, liver enzymes, or arterial blood gas, depending on the clinical diagnosis. It may also require toxicology screening and some forms of imaging, including a chest X-ray and abdominal ultrasound scan, sometimes endoscopy, either in the form of flexible esophagoscopy or a gastroscopy, would also be required. The management should start with the simple home remedies. Simple things like drinking a glass of water, sipping iced water, or swallowing crushed ice, eating a spoonful of granulated sugar or peanut butter, chewing on a lemon, or sniffing pepper powder in order to induce a sneeze, sometimes increasing the partial pressure of the carbon dioxide by certain maneuvers like Valsalva maneuver or breath holding or breathing into a paper bag would also help. Rubbing or stimulating the soft palate digitally or with a swab could also stop the hiccups, and compressing the diaphragm by pulling the knees up to the chest could also help. If the simple home remedies fail to suppress the hiccups, then we move to the second-line techniques that require some caution, including things like carotid bifurcation massage, applying pressure on the eye or supraorbital area, digital compression of the root of the neck over the course of the phrenic nerve, compression of the thyroid cartilage, or instilling some irritants into the nasopharynx, including vinegar, for example. These procedures should be taken with care. They are not risk-free. Vagal maneuvers can lead to severe bradycardia, and the application of irritants into the nasopharynx can also have some corrosive effect. The next step up the management ladder would be through medications, primarily for gastric irritation or gastric distension. This would include one or more of the following three groups. Medications to reduce gastric irritations, including proton pump inhibitors, omeprazole, lansoprazole, or pantoprazole, combined with a prokinetic to enhance gastric emptying. Primarily, the commoner drug for this group would be the metoclopramide at a dosage of about 10 milligrams 3 times a day, but there are other alternatives, including domperidone, etopride, and also an antiflatulent or a defoaming agent like simethicone or a carminative agent. The next step would be to try anti-epileptic or anticonvulsive medications, starting with the GABA agonists, things like baclofen. This is a GABA B agonist, which has a presynaptic inhibitory effect on motor neurons. It's widely used as an anti-epileptic to reduce spastic contractions in the skeletal muscles in various neurological conditions. Besides its central effect, it also has a peripheral effect on the vagus. Particularly, it inhibits the transient relaxation of the lower esophageal sphincter and thereby helps in preventing gastroesophageal reflux. The dosage is of 5 milligrams twice daily, up to 20 milligrams 3 times daily, but only for 5 days. It should not be used in patients who have renal impairment or in the elderly because of the side effects that include things like ataxia, delirium, dizziness, and sedation. The other GABA agonist that has been increasingly used in the treatment of intractable hiccups is gabapentin. It's an analog of the inhibitory neurotransmitter, and it is widely used in the treatment of epilepsy. It's also used in cancer patients and palliative care medicines for neuropathic pain management. It is tried in intractable hiccups widely, and there are about 35 different reports about its efficacy and the management of the hiccups. It's particularly useful in patients who have hiccups related to CNS pathology, like brain tumors. Start with a burst dose and then taper the dose to stop within a few days. It has less side effects than other anti-epileptic medications, but the usual dizziness or transient sleepiness and sedation may occur. The next group of medications include dopamine antagonists, starting with chlorpromazine, which was at one point the only medication licensed particularly for hiccup control, and it was approved by the US Food and Drug Administration for that reason for many years. It acts centrally by its action as a dopamine antagonist, but it has serious side effects, including hypotension and urinary retention and glaucoma, and for that reason, it's no longer considered a first-line medication in the treatment of hiccups. The usual dosage is 25 milligrams 4 times a day. That can be increased to 50 milligrams if required. The other dopamine antagonist is metoclopramide, which not only have an anti-dopamine effect, but also a serotonergic effect. It stimulates the serotonin receptors. It has a central effect through these neuromediators and also a peripheral prokinetic effect, which is very useful in the cases of hiccups because it enhances gastric emptying and reduces gastroesophageal reflux. The dosage is 10 milligrams 3 times a day for only 5 days. Another dopamine antagonist that may actually be better tolerated than chlorpromazine is haloperidol at a dosage of half milligrams to 1 milligram, and then a maintenance dose of 1 milligram to 3 milligrams only at bedtime. We now move to other groups of medications that are not commonly used as a primary management of hiccups, but may have a role to play in some resistant cases, starting with local anesthetics, things like lidocaine that can either be used in the intravenous infusion form very slowly in a monitored patient, or in nebulized inhalation form. In the intravenous infusion, the major drawback is the risk of cardiovascular or neurological toxicity. Therefore, the patient should be monitored and the infusion should be very slowly over a period of 45 to 60 minutes. And the nebulized form can be effective by blocking the sensory nerves in the throat, but it can, of course, have the risk of aspiration. So the patient should not be eating or drinking for a good while after the lidocaine, at least an hour. And just to complete the list of the uncommon medications with only a narrow but specific action in the management of intractable hiccups, amitriptyline can be tried in a dosage of 10 milligrams 3 times daily. Carbon dioxide 5% can also sometimes be useful. Methylphenidate can be useful through its anti-dopaminergic effect, but also particularly helpful in patients who have concurrent depression, for example. Midazolam can be used as a continuous intravenous infusion, short of producing sedation. So to sum up, the first step in the management should be to try the non-pharmacological measures, including the home remedies and the various techniques to stimulate the vagus or the phrenic nerves. If these fail, then we move to medications aiming at reducing gastric irritation or gastric distension, including things like thymicone, for example, which is an antiflatulent, a prokinetic like metoclopramide, and a proton pump inhibitor. If this fails, then the next thing will be a GABA agonist like baclofen, provided that the kidney functions are working well. If this fails, you can try the other GABA agonist, the gabapentin, or if there is a problem with the kidneys or the patient is elderly, you may try the dopamine antagonists. Things like chlorpromazine and the haloperidol can be tried. If these fails, then you consider the other options, including the nifedipine, the calcium channel blocker, or dexamethasone, for example, if there is CNS compression, or sertraline, that is a serotonin receptor agonist. And finally, if all these fails, you may try sedation by midazolam, for example. Again, in some very resistant cases, other forms of therapy have been tried, including stellate ganglion blockage. This can be achieved by injecting a local anesthetic, things like ropivacaine, for example, aiming at the transverse process of C6, manually trying to identify the carotid sheath and retract it a little bit laterally, and then aiming with a needle to the body of the transverse process of C6, injecting about 8 milliliters of the local anesthetic in there. This will induce immediately a Horner syndrome, but also was reported to cause cessation of the hiccups. And in very refractory cases associated with significant discomfort and morbidity, things like disruption of the phrenic nerve were also tried. And this can be either achieved by a long-acting local anesthetic injection over the course of the phrenic nerve, or even surgically disrupting the nerve itself. This would cause serious impairment in the pulmonary function and should only be reserved for very well-selected cases, can be justified only in the very extreme and resistant cases. By this, we come to the end of this presentation on the persistent and intractable hiccups. Salam alaikum.